benign condition, some malignant condition. These are the diseases I am going to discuss and the cutaneous manifestations. We see the skin lesions associated with particular condition. There are list of conditions. If I am going to discuss all the things, I will summarize the things and important features I am going to discuss here. Skin in liver is pruritus. It is one of the cutaneous manifestation of liver disease, but it's not indicate liver disease. There are different differential diagnoses. We need to know about that, and we need to see the associated features. Clinically, we need to assess whether there is any feature suggestive of liver disease, with not only the cutaneous manifestation, the other systemic features also. And also we need to see the other differential diagnoses and those features. After clinical assessment, we need to do the investigation for those. Mainly the liver disease, kidney disease, and anemia, polycythemia especially. After hot bath, they will complain itching. That is kind of specific for polycythemia. Hypothyroidism, diabetic and lymphoma also can present with this pruritus. Depending on the age and other clinical scenario, will suspect what is the condition. And diffuse hyperpigmentation. It is again in liver disease like hemochromatosis, they will have hyperpigmentation, diffuse hyperpigmentation. Also in renal disease and at the start of systemic sclerosis like that, they will have diffuse hyperpigmentation. Spider nevi, there will be a central arteriole surrounding capillaries. It looks like a spider. One of the cutaneous manifestation of liver disease. It also seen in pregnancy, some oral estrogen therapy like combined oral contraceptives and other thyrotoxicosis conditions. Palmar erythema of theina and hypotheina eminence. Sometimes even at soul, it affects the soul also. It can seen in liver disease, again the pregnancy, thyroid conditions. White nails, it's associated with hypoalbuminemia. Hypoalbuminemia can be seen in liver disease. These congestive heart failure, malnutrition, those conditions also they can have these white nails. This is porphyria cutanea tarda, defect in some hepatic enzyme, and it's present with photosensitivity. And in the, especially in exposed area, they will have tense blisters. Blisters, there are flaccid and tense blisters. Tense blisters means difficult to break. It takes time, more than 24 hours, even 72 hours to break, because it's very deep layer. You know the skin layer, very superficial one is epidermis and deeper part is dermis, and below that subcutaneous tissue. These vesicles are produced at the level of dermis. When they produce the tense blisters, when they heal also they will heal with the scarring. And another features we can see here, with the scar they will form a milia, whitish papular lesion over the scars. And if you see these pictures, you will think about hyperlipidemia, scandalesma, and eruptive xanthomas. But not only in hyperlipidemia, some other conditions also can present with these xanthomas. And one of the conditions is primary biliary cirrhosis. When there is a xanthoma associated with hyperpigmentation and pruritus, we need to think about some other condition like primary biliary cirrhosis other than the hyperlipidemic conditions. is zoonotic crusty syndrome. It's rare and it's associated with post-hepatitis B virus infection in children. They will come with the papules and vesicles of the extensor surface of the limbs. And this is granuloma annulare. Again, it can be seen in hepatitis B, also diabetic patients and HIV infection. In children, it's most of the time benign. Again, I am telling these features not specific to this condition. Most of the time, those are benign, but these causes also present with this manifestation. Vasculitis. Vasculitis, there are small, medium, large vessels. Vasculitis are there. Hepatitis B present with polyarteritis nodosa. It's a medium vessel vasculitis. Not only the purpuric lesion, non-branch purpuric lesion, they will present with ulcerations. In small vessel vasculitis, usually these non-branching purpuric lesions will be there. When the vessels affected is large, it also present with ulceration. Cryoglobulinemia present in hepatitis B and C infection, they will present as small vessel vasculitis. Renal manifestation, acquired perforating dermatosis. It's high disease. They are coming with itchy papular lesion, mainly proximal limbs. Hyperpigmented papular lesions with central keratotic materials. If you don't know this condition, you will not suspect this type of conditions, especially elderly middle age. Patients with renal disease and also diabetic, they can present with this type of lesions. We can confirm it with histology and clinically we can diagnose. If we want to confirm, we can go for the biopsy also. And the problem is usual antihistamines, it won't answer for this itching. We need to consider other treatments. This is calciphylaxis. Calciphylaxis means vascular occlusion causing necrotic in the shape of vascular distribution, like stellate shape necrotic lesions. Retiform purpura, preceded by retiform like purpura, followed by this necrosis. In renal disease, it's due to calciphylaxis, occlusion by calcified materials. This type of presentation can be seen in anticoagulant therapy and some other conditions where the vascular occlusion, not only calcified material, if other occlusion also can present with this necrotic purpuric lesions. Calciphylaxis in renal disease, especially the end-stage renal disease. Pruritus I mentioned earlier, and hyperpigmentation, one of the causes renal disease. The name changes are half and half name in renal disease. In liver disease and other hypoalbuminemic condition, white names, here the half and half name. Pseudoporphyria, here the porphyrin levels will be normal. In liver disease, because of enzyme deficiency, porphyrin levels are increasing. They present with this tense blister photosensitivity rash. But here again the clinical presentation is same. The difference is the porphyrin levels will be normal. Uremic thrust, these features these days it's difficult to see because of introduction of dialysis and all. Patients are not allowed to stay with high azotemic conditions. When there's high urea in the blood, it's secreted in the sweat, then it crystallizes and forming this type of lesion. It was there earlier, we can't see those type of patients now. And in renal manifestation, transplanted patient usually they will be on immunosuppressive therapy and they have a high chance of abnormal manifestation of various infection and these viral ward. Oral cavity is having the viral ward, and I just put another picture. This patient is on cyclosporin. They can have skin lesion due to immunosuppression and also immunosuppressive therapy. Patient on cyclosporin, they can develop acneiform lesions and hypertrichosis. What is hypertrichosis? Excessive hair growth. There's a difference between hypertrichosis and hirsutism. What we have is vellus hair in the body, terminal hair in the scalp. When the vellus hair is turning to terminal hair, if it is on the androgenic distribution, it is hirsutism. If it is there in the other parts of the body also, it is hypertrichosis. Hypertrichosis and acneiform lesions can be there in cyclosporin treating patients. This is hyperlipidemia. There are various types of familial hyperlipoproteinemias. They can present with Sandalesma palpebrum and tuberous xanthoma when these lesions are large in the extensor surfaces, and tendinous xanthomas, eruptive xanthomas usually in the buttock regions, and plain xanthomas along the skin creases, and as I mentioned earlier, xanthomas not always indicative of hyperlipidemia. These type of plain xanthomas form of histiocytosis. Clinically they present as xanthoma, but they are associated with myeloma and leukemia. So they have normal lipid profile. We need to investigate with full blood count and ESR and other investigation with blood pictures to rule out any other associated condition.